Good morning, everyone. My name is Daniel Lee. I'm going to be the moderator for today. I wanted to welcome everyone to today's High Round. As a reminder, today is World AIDS Day, and I think it's always a good time to spend a moment here and there to remember the people that we've lost due to HIV. Luckily, I think the numbers are better than they used to be. However, there's still a lot of work to be done. I also think this is a time of celebration to celebrate all of the people that are here in this room, but also online, who are involved in the care of people with HIV. So with that said, I have the pleasure of introducing Dr. Annick Borquez. She's an associate professor at the Division of Infectious Diseases and Global Public Health here at UCSD. She's a substance use and HIV epidemiologist focused on the health of marginalized populations, including people who use drugs, people experiencing homelessness, men who have sex with men, transgender women, okay, and men, and transgender women, and sex workers. Her research examines risks and epidemic dynamics for HIV and overdose, as well as the potential for interventions to reduce their incidence and their implementation. She applies dynamic, statistical, and machine learning methods, as well as qualitative research methods, and is mainly focused on the US and the US-Mexico border region, but has long-standing collaborations with Peru, the UK, and Australia. So welcome, Dr. Borquez.
Thank you. Good morning, everybody. Can't believe it's December already and that we're all here fully dressed at 8 a.m. on a Friday. So I think that shows commitment to the cause. So I'll be talking about PrEP among men who have sex with men and transgender women today. I'll give an update on the ImPrEP demonstration project in Brazil, Mexico, and Peru. I'll mostly be talking about Peru because that's where I've been working, but I'll give a general overview of the study. And I'll also be talking about the ENCORE study, which is a study among transgender women in the US. That's very early stage yet because we're still in the recruitment period. So it's more about telling you what we plan to do with this study. Okay, no conflicts of interest to declare. Thank you, Marvin. And just a little bit of background on the ImPrEP study. So in Latin America and the Caribbean, only 15 out of 46 countries have access to PrEP. This is for 2022. It might be a little bit, I took it from a paper and then tried to add the countries that I knew had PrEP since then, so it might not be the exact number, but just to say that Latin America is late in terms of implementing PrEP. And so this study, the ImPrEP study that was funded by UNITAID, meant to accelerate the pace of scaling up PrEP in Latin America. And so it aimed to assess the feasibility of delivering same-day oral PrEP among men who have sex with men and transgender women in Latin American countries at different stages of PrEP implementation. And so the three countries that were involved were Brazil, Mexico, and Peru. In Brazil, PrEP is available through the Ministry of Health, so through the public health system since 2017. The study started in 2018, so they had already started providing PrEP, whereas for Mexico and Peru, this happened later. It happened in 2021 in Mexico, so just after the end of the ImPrEP study, and in Peru this year, which was a big achievement because the public health system really suffered during COVID, and there was a lot of, it was very hard to get that passed through because it wasn't felt as a priority anymore given the circumstances. So it was an achievement to get PrEP provided by the public health system. So basically it was three countries at very different stages in the implementation of PrEP, and the expectation was that Brazil was going to lead the way as it has for many other health and HIV in particular related issues. PrEP was delivered among over 9,500 MSM and transgender women between February 2018 and June 2021. And is there a little, oh yeah, okay. So there were 4 sites in 3 cities in Mexico, and about 3,300 participants were enrolled, 10 sites in 6 cities, in Peru with almost 2,300 participants and 14 sites in Brazil in 11 cities with almost 4,000 participants. So it was a very large study, and as I said, the overall goal was to foster South-South collaboration for knowledge exchange and disseminations of lessons learned and good practices. So the hope was that the experience of these 3 countries is going to help other countries in the region in terms of scaling up PrEP among these populations. And so it was a big study, and it had lots of different components and goals. So I'm going to take you through the main goals today so that you have an idea of what was done, but I'm only going to be presenting about the modeling, which I was in charge of. I don't know why, but I'm not sure where this thing is. Okay, so the main goal was assessing PrEP delivery, as I mentioned, so assessing the feasibility of same-day oral PrEP generally in public health clinics and non-governmental organizations that provide health and STI services for men who have sex with men and transgender women or the general population, and to assess uptake of PrEP, retention and adherence among these groups, as well as, of course, measure HIV and STI incidence over the course of the study. The second goal was to assess PrEP awareness among both MSM and transgender women, but also providers. And so there was an online study that was done separately. It's a different sample, basically asking questions about awareness and willingness to uptake PrEP for MSM and transgender women. And for providers, it was regarding attitudes and willingness to prescribe. So all of the studies that were published in regards to this one are not directly related to the ImPrEP sample. Then there was a sero-incidence study, and that was among individuals that were eligible to use PrEP according to the ImPrEP protocol, but again, it wasn't among ImPrEP participants. It was done in parallel in the sites which recruited or enrolled ImPrEP participants, and that was done to check whether ImPrEP was being provided in settings where HIV incidence was high. So basically confirming that these are the right settings for PrEP provision because they are being reached by people with a higher HIV incidence. And then there was a qualitative component, and this was basically to understand patterns of PrEP use in terms of uptake, but retention and adherence in particular, as well as among providers to inform the scale-up once PrEP was a little bit more established in the community. And the modeling and cost-effectiveness analysis component is the one that I was most involved in, and it was basically to inform cost-effective scale-up of PrEP in these different settings. And finally, there was a component which was all about demand creation, and this basically aimed to foster community mobilization and demand creation. And so there was a lot of social media activity as well as events so that people were more aware of PrEP and so that they would be more likely to ask for PrEP. This was also, in a way, I know, especially in Peru, because we still didn't know whether it was going to be incorporated into the public health system. And so they were worried that if there was no demand, there was going to be no provision. And so it was like, okay, let's push so that there's demand from the community to help us actually justify the need to the Ministry of Health. And so just so that you know how the study was implemented, eligibility was participants had to be HIV negative, they had to be cisgender MSM or transgender women, age 18 years and older, and they had to report one or more of the following criteria in the previous 6 months. And that was following the Brazilian PrEP guidelines because the other 2 countries didn't yet have guidelines. And so this was either condomless anal sex with a partner or partners dealing with HIV, reported rectal or urethral gonorrhea or chlamydia, syphilis, or transactional sex in the past 6 months. And in terms of the study visits and measurements, I don't know if it's me or if it's temperamental, but anyway, So the follow-up visits were at week 4, and this was basically just to assess whether there was acute HIV infection, so to ensure that they weren't giving PrEP to people who were already HIV positive, but who came up negative in the first 4 weeks, and then it was quarterly thereafter until study termination, so in the same way that PrEP is implemented elsewhere. And for individuals who returned more than 24 weeks after any visit, they were required to re-enroll. This is important, and I think we didn't expect this to be so important at the very beginning of the study, but because it happened just during COVID, there was many clinics closed, but also many participants just disappeared over that period. And so many participants had to re-enroll. And there's a big difference in HIV incidence among those who had to re-enroll and those who didn't. So I'm not going to get into that, but interpreting the ImPrEP study is quite difficult in the sense that it happened in a very difficult period and that there was very strict closures, especially in Peru. And yeah, there's been a lot of criticism about how the pandemic was managed in Peru in that sense. But and so yes, there were quarterly HIV and syphilis testing and annual chlamydia, gonorrhea, HPV, and HCV testing. So it was quite comprehensive in terms of biological measurements and quarterly measurements of sexual behaviors and PrEP adherence. And so for those who are interested, this is a study that basically presented the protocol and like the most important results or the key results. It was the first author is Valdilea Veloso, who is the PI of the Brazilian site, and basically the Brazilian site is the main site, and the other two are in a way subcontracts. Carlos Cáceres is the PI for the Peruvian, and Hamid is a PI for the Mexican side, although the PI changed at some point during the study. So main findings, very, very briefly, about 6% of participants were transgender women, 94% were cisgender men, 26% were age 18 or 24 to 24, sorry. And in terms of retention and adherence, 8.4% had early loss to follow-up. This changed a lot between the studies. There was a much higher loss to follow-up among Peruvian participants. 68% were adherent to PrEP. 70% had long-term PrEP engagement. And in terms of factors associated with retention and adherence, early loss to follow-up was most common among transgender women, participants who were young, and those with primary education as opposed to higher levels of education. Lower PrEP adherence also among these same participants, and lower long-term engagement, again, among transgender women, young participants, and those with secondary education. This last finding was a little bit hard to interpret, and we're struggling interpreting anything related to education in this study for some reason. And in terms of HIV incidence, it was 0.85 per 100 person years among ImPrEP participants. But I'll be talking more about incidence. And again, it was higher for participants who were transgender women, those who were from Peru, those who were young, Black and mixed race, and obviously not adherent to PrEP. So I'll give you a bit of a bombardment of papers just so that you get an idea of what has been investigated in the context of PrEP, of the ImPrEP study. So some of the early studies investigated willingness to use pre-exposure prophylaxis based on the findings from the web-based survey, trying to identify whether those who identified themselves as being at high risk of HIV were more aware of PrEP. Again, awareness, knowledge, and attitude related to HIV pre-exposure prophylaxis based on the web-based survey. And then there was more specific studies assessing barriers and facilitators to PrEP once this was implemented among the ImPrEP participants. There was also, as part of the cost-effectiveness analysis, discrete choice experiments that were implemented in the 3 countries. Here, this is presenting results for Brazil, but there's also papers coming up for the other 2 countries in terms of understanding preferences for PrEP delivery among MSM and transgender women, understanding barriers and challenges to PrEP adherence. This was all from the 2021 IAS conference, and some of these papers are about to come out, but I can't cite them yet, so they will be appearing. But one component of the study that I didn't mention is that at some point they introduced event-driven PrEP, and there's some information on who chose to engage in event-driven PrEP. And then finally, early predictors of seroconversion among enrollees in this study. So now I'm gonna talk to you about the modeling component. I've already presented on this in the past, so I think I'm gonna bore a few people either here or on Zoom, but I'll try to streamline because I also want to have time to speak about the ENCORE study. But basically the modeling component aimed to estimate the potential population level impact of and cost effectiveness of PrEP scale-up among these populations in the next 5 and 10 years. I'm mostly focused on the 10-year horizon so far, based on observed sexual behaviors, PrEP use patterns, and incurred costs in the ImPrEP demonstration project. So basically, lots of studies have been done investigating the potential impact and cost effectiveness of PrEP, but using data from the randomized control trials. So this was our first opportunity to do this with real-world data and among participants who were receiving this at STI clinics, that is the standard of care in each of these countries. And so the expectation is that we will get much more realistic estimates of cost effectiveness and impact as well. So, yeah, to identify scale-up strategies to maximize impact with available resources. Given that these programs are at a very early stage in all of these countries, the idea is to inform the Ministry of Health about which populations to prioritize and how to deliver PrEP so that resources are maximized. So yeah, basically guide the implementation of PrEP among these populations as a public health policy in Peru. So this is a diagram of the mathematical model. It's a compartmental model. So people who share the same characteristics are all in the same compartment, basically. And so we have 4 main groups that are represented here. Homosexual men or men who have sex with men who report exclusively having sex with other men. Bisexual men, so those who report identifying as bisexual and sometimes also having sex with women, sex workers, and here I'm referring to male sex workers, and transgender women. And some of the transgender women represented here are also sex workers, but they're all brought into the same group. And here they're subdivided into their main role during anal sex. And so for homosexual MSM, well, MSM who identify as homosexual, we have them split into mostly insertive, receptive, or versatile. For bisexual men, very few report being exclusively receptive, so we ignored that. We neglected in a way that category, and they're only divided into these 2. Sex workers into the 3, insertive, versatile, and receptive, and transgender women mostly report receptive anal sex, so we're only representing this. I think if I were to do this again, I would probably also incorporate a versatile, because we know that there's under-reporting of insertive anal sex among transgender women. But there's also a big push for the model to be as parsimonious as possible, because the more complicated it is, the harder it is to interpret and also to parameterize it. And just so that you get a sense, well, and the arrows just represent the mixing patterns between the groups, and the thicker the arrow, the more sexual context there is between these populations. And so, and in terms of the distribution of the population by group, about 60 to 70% are men who have sex with men who identify as homosexual. Then we have about 20% who identify as bisexual, about 15% who are male sex workers, and a smaller proportion of transgender women, around 5%. And yeah, this is a model that was initially developed many years ago when PrEP became, when it was found that PrEP was effective at preventing HIV among MSM and transgender women. And I've been modifying it for the past 10 years, so it's become a bit of a monster because it does many things right now. So the model is basically calibrated to data on prevalence of HIV among each of these groups through time. that we get from HIV incidence, sentinel surveillance, basically data. Sorry, HIV prevalence from sentinel surveillance data. We also calibrated to HIV incidence data and ART coverage, but I'm not showing you everything here. I just want to focus on basically the fact that we try to make the epidemic fits basically go through the data points. And Peru is interesting in the sense that they've been carrying out sentinel surveillance since 1996 among men who have sex with men and transgender women. So there's a lot of data to inform the model, and the idea is that the better the model fits to historic data, the better it is at reproducing the patterns that are leading to that incidence. So just to tell you how the analysis is actually implemented, so we get this baseline prevalence curve or incidence curve. In this case, I'm showing you the number of new infections. Of course, we don't only work with one epidemic, we work with all of the selected epidemic fits, but this is just a simplification to show you how it's done. And then we implement the intervention between 2022 and 2030, so the PrEP intervention, and this leads to, of course, a much lower rate of new infections, and we calculate the number of infections that were averted over that period of time. And basically, these HIV infections averted are converted into disability-adjusted life years. I don't know if everybody is familiar with these disability-adjusted life years, but they basically are a standardized measure of the days that are lost to either disease or death for across diseases, and so it's easier to compare the effectiveness and cost effectiveness of interventions across diseases when you have a standardized measure. Then we estimate costs for 1 year of PrEP, and this was done basically through the data from ImPrEP, and we discount benefits and costs over time, and finally we estimate cost per daily averted. So in terms of modeling the PrEP intervention, we assumed a coverage of PrEP of 20% of the men who have sex with men and transgender women population. The distribution of PrEP by group was basically corresponds to the proportion of treatment allocated to each group, and it was identical to that observed in ImPrEP, and that's what's important because basically it just represented the population that came into the ImPrEP study. We did it in exactly the same way, and same for adherence. It's a proportion of sex acts protected by PrEP. And it was based on the medication possession ratio and pills missed for each group. Again, so exactly representing what we saw in ImPrEP. And then the implementation period, we assumed that it would reach 2 years to reach 20%. And that then it would be kept at 20% coverage between 2024 and 2030. In terms of the costing, we implemented a micro-costing analysis. We didn't include personnel because there was a lot of debate around this, but the expectation is that the personnel is already there in those STI clinics and that they would be providing these services anyway. There's arguments for saying, well, yes, but this is additional work for them, so there's probably going to be a need for hiring new people. So anyway, I'm doing a sensitivity analysis with and without personnel to make it easier, but I'm showing you the results without personnel because that was the agreement with the Peruvian team. And so it was estimated that 1 year of PrEP costed $445, and this was assuming a cost of PrEP drugs of $120 per year, which is very, very low, but it is achieved using the PAHO Strategic Fund, which provides generic treatment, and it's about 4 times lower. The cost is about 4 times lower than Truvada. And this is actually what's happening right now in Peru. So otherwise, it was completely not cost effective, and there was no point of even studying PrEP because, Truvada was too expensive. And this is just for you to get an idea of how the costs are distributed. So mostly spent in diagnosis and the drugs, even if these are cheap. And so this is the main result in terms of the modeling. So in terms of PrEP impact, we estimated that if you gave PrEP to 20% of men who have sex with men and transgender women, you would avert 25% of infections over the 2020-2030 period. But this varies by group. And so we can see that we would avert many more, a higher proportion of infections among transgender women, about 45%, about 30% among male sex workers, and closer to 20% among these other populations. And so here we see the total, which is the 25% that I presented. This is a median, but I'm presenting here the mean, so that's why they don't match very well. The reason for this is because there was a very high proportion of ImPrEP participants who were transgender women and male sex workers, and because their incidence was higher. So this is why the impact is higher among these groups. And in terms of cost effectiveness, we had to also calculate the cost of ART provision, because we want to know in terms of averting HIV infections, we're also averting costs of ART, so it was important to incorporate this. And so the cost of 1 year of ART was estimated at $510 per year. And so the cost per DALI averted with the PrEP intervention was estimated at $1,300 with a relatively large confidence interval that's associated with the uncertainty both in the epidemic and in the impact of the intervention. And this is within the WHO cost effectiveness threshold of 1 GDP per capita, but this is pretty much all interventions will be cost effective under the WHO threshold. It's a very generous threshold. And so we also used thresholds that were specifically estimated for Peru based on their expenditure and expenditure in health and associated mortality. And so there was a study that estimated that the cost effectiveness threshold was between 1,969 and 7,000. I mean, something that was basically close to the WHO criteria, but we were using the low bound here. And so we see that PrEP is cost effective even with this more stringent threshold. And when accounting for ART costs saved between 2030 and 2060, so basically in this scenario, we only provide PrEP between 2022 and 2030, but we run the model until 2060, and we look at savings in terms of not providing ART to the people who did not get infected during those years, thanks to receiving PrEP. And so if we take that into account, PrEP cost effectiveness is of, well, the cost per DALI averted is of $587. So that's very low, and that's way lower than the most stringent threshold, which was estimated by a group at the University of York, a group of health economists. They estimated the cost effectiveness of their low bound was 1,300. So we can see that this is much lower than the 1,300. So basically, our findings indicate that PrEP would be highly cost effective in Peru among men who have sex with men and transgender women, even when using stringent cost effectiveness thresholds. I want to be mindful of the time. That clock doesn't work. 8:30. 8:30. Okay, yeah, I need to hurry up. So yeah, I'm actually gonna just jump this one. Well, I'll just tell you very quickly. One of the goals of the modeling was to see what PrEP coverage would we need to achieve the UNAIDS HIV incident reduction goals. And basically, we estimated that we would need to cover about 50% of MSM and transgender women with PrEP to achieve that reduction by 2030. So all of that is very good, and it was ready to be published and everything, but the results of the incidence studies came up. And so the model incidence in 2019 from the model is basically 2.2% per year. And it's 2.9% among the subgroup that would be accessing PrEP. This is the incidence is higher among the population accessing PrEP because there's a higher proportion of transgender women and of male sex workers in that group. And so the expectation from the beginning was that the model would reproduce what we would see, because we would expect that people at higher risk of HIV would be more likely to be seeking PrEP. And so and that this would just be on the basis of more transgender women and more male sex workers accessing PrEP services. And in terms of reproducing incidence, it was close to what had been observed over time in other studies, so between 0.03 and, I mean, this study was a very particular population, the last one, but basically the expectation was that incidence had reduced a little bit over time in the past 5 years, and well, the model fit this data. However, so as I say, it was consistent with prevalence from surveillance and other local studies, and also with incidence from these studies. But when the incidence studies came out, this was quite different. So the incidence that was measured among patients that accessed the sites in Lima and Callao, which is a city that's basically stuck to Lima, the incidence was closer to 7 and 8%. So about 2 to 3 times higher than what we had estimated here. We had estimated it would be 3%, it was basically 7 to 8%. So this is, that 7% is among those who were not receiving PrEP, but who were used as a sample to confirm that those sites were actually seeing patients that would have a higher HIV incidence. And then the results of the incidence estimates for the ImPrEP also came out. And for those who had low PrEP adherence, which would be close to the baseline incidence among that, that population, was closer to 4.5%, 4.6%. So basically all that to say that the incidence observed among the population receiving PrEP in Peru was quite a bit higher than what I had estimated with the model. So this is problematic because I can't be presenting results for a model that doesn't reproduce the observed incidence. So basically, we needed to go back to the drawing board and incorporate an additional risk factor to have higher incidence among those receiving PrEP. So the original assumption was, because we are representing the distribution of the different groups in PrEP, we will be having a higher incidence among PrEP participants, and it will reproduce what's happening in reality. And yes, we get a higher incidence among those accessing PrEP, but it's not high enough in terms of what was observed in that study. So, for some reason, well, it doesn't matter, but that was basically showing you the results of those 2 studies and showing you how it aligns with, well, how it is associated with different factors. And so the main messages was that it's associated with age. Younger MSM and transgender women had a higher incidence. Transgender women had a higher incidence, which we expected, but there's not very much information on what's driving this higher incidence. And so what I've been trying to do is to identify what's driving higher incidence among men who have sex with men accessing PrEP in comparison to the sentinel surveillance, basically. And so I was thinking, well, maybe people who are accessing PrEP are younger than in the incidence, in the sentinel surveillance, but actually there's a very similar distribution in terms of age. I was also thinking, well, maybe people who are accessing PrEP have a lower income because they're going to these public health clinics, public STI clinics, but I compared income among ImPrEP participants and income among sentinel surveillance participants, and it's also similar. Similar for education, and actually education is slightly higher among ImPrEP participants, and actually income is also slightly higher among ImPrEP participants compared to sentinel surveillance. I thought, well, maybe it's because, obviously, because we're working from public STI clinics, there's more patients that are accessing the STI clinic versus in the sentinel surveillance. Again, it is similar. And so we thought, well, it's maybe just because of the fact that ImPrEP selects people based on their HIV risk behaviors, that they have to have a certain level of risk in order to access PrEP. But we compared these to the Sentinel surveillance, and in the Sentinel surveillance, 72% of MSM and 89% of transgender women would be eligible to for PrEP, according to those criteria. So, I mean, this tells us something. There is definitely a little bit of a higher risk among those accessing PrEP, but it's not as high as we would expect. And so finally, the last hypothesis is that those who we see in the ImPrEP study are seeking HIV testing and prevention. And so basically, they are probably engaging in higher risk. And that's what's leading to this population having a higher incidence. So the plan is basically to, now the model incorporates an additional level of risk. We need to determine the size of this group with higher risk and to parameterize and recalibrate the model so that we can reproduce these incidence patterns, rerun the analysis. And the expectation is that PrEP will be more cost effective with these new results because incidence is higher. And so when you provide PrEP to a population with higher incidence, the impact will be greater. But we also saw quite low adherence. Quite high incidence among those with low adherence. So it's going to be interesting to compare the results. And we also expect that the coverage estimates to achieve the UNAIDS incidence goal will change. And so we will be presenting the two outcomes. So everything I showed you today plus these new results, because the new results are also probably driven to some extent by the COVID pandemic. So we're not sure that these same levels of high incidence are going to be true in the future. So better to present both results, but need to be transparent. And then the next stage, so the next research question, which is waiting in line for me to finish this first analysis, is to explore the potential impact of providing long-acting injectable formulations or a hybrid program that provides long-acting injectable oral, but also event-driven PrEP. So this is being implemented in Brazil. They're providing long-acting PrEP now. The ImPrEP study kind of extended. They're not providing it in Peru because it's not approved yet in Peru, but we're doing this theoretical analysis to see, well, if long-acting PrEP was provided in Peru, what would be the impact on the cost effectiveness and on impact. So that's it for the ImPrEP study. I'm now going to be telling you about the ENCORE study. I think some things have changed in the slides, but bear with me. So the ENCORE study is a study that's for transgender women and trans feminine people in the United States and Puerto Rico. It's a digital cohort study, so participants are recruited online, and all of their participation happens online. They receive an HIV test at home. It's actually an HIV sampling test that they send back with a prepaid envelope, and that's then processed in at the Johns Hopkins lab, and they get the result by phone. And this is a follow-up of another cohort of transgender women that finished a couple of years ago, and that was implemented in Eastern and Southern United States. The ENCORE study actually is national, so they're covering all regions, but it is very much an extension of this light cohort. And so it's led by Andrea Weirtz at Johns Hopkins University and Sari Reisner at Harvard School of Public Health. And there's co-investigators at 6 sites: Atlanta, Baltimore, Durham, Miami, New York City, and San Diego. And I'll tell you more about why these 6 cities are important. And there's also co-investigators at community organizations. So Ariana Center, Black Trans Advocacy Coalition, and Trans Solutions Research and Resource Center. So those were involved from the design of the study as they were during the light cohort. So this is just, again, to bombard you with some of the papers that were published from the light study so that you get a sense of what the research is aiming to, to kind of investigate. So basically presenting the protocol and the online light cohort. Again, HIV awareness and prevention strategies among transgender women in Eastern and Southern United States. It's all going to be Eastern and Southern because that's where the study happened. They didn't extend to other regions. They looked at HIV incidence and mortality. They looked at, the studies are very focused on PrEP, and so there's lots of questions about PrEP engagement, retention, adherence. So it's been providing information on that. Yeah, HIV acquisition, low uptake of PrEP, characterizing arrest and incarceration. So those are some of the questions that were investigated. And this is basically illustrating the ENCORE study, so the follow-up study. And so the reason I was talking about those 6 cities is because while the study is online, there are 6 cities that are considered hubs in which it is possible to actually provide in-presence support to participants. So any participant who can't participate, when any potential participant that can't join the study because of low access or low internet literacy, or because they don't trust an online study without actually engaging with somebody, they can actually receive help from a real person in these 6 sites. And I'm actually counting 7, but something must have changed in between the graph and the reality. But San Diego is one of them. And so I am the site PI for the San Diego study, and we're basically trying to enroll people in presence and to provide help in terms of if they want to test at a clinic here, anything that they need, if they need to fill in the survey with some help, we're there to help. But it's also with the expectation that the populations recruited at these 6 cities will be more representative of the real community, because we're engaging with local, hi David, because we're engaging with local community-based organizations who work with transgender women. And so they're reaching out to people that might not even have found out about the study had they not been in contact with these organizations. So there's a lot more dissemination about the study than in places where it's only done online. And so this is the flow diagram in terms of timelines. The enrollment started in spring of this year, and then participants are followed up every 6 months. And so there was a 3-month period, well, it was more like 2-month period of enrollment during the spring. Now we're still going through the fall enrollment that started in September and will end in December. The idea was that over these 2 periods of enrollment, 3,000 transgender women would have been enrolled in the study. Enrollment has been really slow, and so there's going to be another period of enrollment in the spring of 2023. But basically, participants get like reminder of filling their survey every 6 months, as well as an HIV test every 6 months, and this is going to be ongoing until 2025. This basically tells you the same thing, so I'm gonna skip it, but just so that you get a sense of the flow. Participants have to be HIV negative to participate, because this is very much focused on HIV incidence, and otherwise the sample would have to have been even larger. It has been difficult to work with a study that excludes HIV positive participants. I must say that it's quite uncomfortable, and if it was my choice, I wouldn't do it this way. But it's also difficult in terms of reaching a sample size that will allow you to say anything about incidence if you're also including HIV positive participants. I think in the future this won't happen anymore, and it will have to be studies that have 2 different goals, looking at treatment engagement and looking at prevention engagement, because potential participants get disappointed when they can't participate because of their HIV status, and this population has a high HIV prevalence. But that's how it's working at the moment, and if they become infected during the study, they participate in a follow-up survey 6 months later to check whether they received care. So in terms of compensation, they receive $15 for filling in the survey, $65 for sending back the HIV testing kit. So it's $80 every 6 months, basically over 24 months. And as part of a service for being a participant, they can require HIV or STI test anytime during the study. This is not part of the research. This is more in a way as a kind of thank you for being participants in the study. In terms of collaborators that are specific to San Diego, I've been working with Proyecto Translatina, and that's Jamie Arangure in that picture on the left, and with the Transgender Health and Wellness Center. So they've been disseminating the study, and they've been helping enroll participants and help participants who are struggling with the study. These are the flyers that we've been sharing, and that if anybody here works with transgender women, I'd be super grateful if you could share it with them. But basically everything is in Spanish and English, because the survey is in both Spanish and English, and there's a big push towards representing Latin American, Latinx transgender women, because they were underrepresented in the light cohort. And so there's two main research axes in this study. One is better understanding the implications of these digital and hybrid cohorts. So there's a big push from NIH to moving towards digital cohorts because they are cheaper, they're logistically, in theory, easier. They're also less burdensome for participants because they don't have to go somewhere to fill in their survey, to do their test. They can do everything from home. So in theory, they are better for monitoring HIV among populations or other diseases among populations of interest. And the idea was that they will be scaled up to have regular surveillance of HIV among these populations. The problem with this is that they underrepresent all those participants who cannot access the study online because they don't have internet access, because they have low computer internet literacy, or even because they have low literacy in general. And so the risk with these digital cohorts is that we will be missing the most marginalized sections of the population. And that's something that was actually shown in the light cohort. The light cohort was much more half in presence, half digital, and they compared the two populations, and they showed that obviously those who were recruited in presence were kind of experiencing higher risks, although it was interesting because it was different types of risks. The ones that were recruited online were experiencing more isolation, more intimate partner violence, more mental health issues, whereas the ones who were recruited in presence, so physically, were more likely to be unhoused, were more likely to be economically deprived. So it was more, they were more exposed to structural determinants of risk. And so that's the idea, again, with this cohort, that we're going to have data from these 6 cities among transgender women that were recruited in presence, and we'll compare to the online sample. And the second research axis is structural determinants of HIV prevention and acquisition. So the survey is very much focused on syndemics, and so it's looking at HIV, mental health, and substance use disorders. And there's many questions focused on racism, violence and discrimination, employment, housing, and exposure to law enforcement. So the main goal is to actually better understand the relationship between exposure to these structural determinants and HIV acquisition, but also mental health and substance use disorders. I think I'm gonna skip, I'm very quickly gonna take you through the aims, but the first aim is determine the efficiency and acceptability of this novel hub-supported digital cohort. So the idea was that if this works, it could be extended, and there could always be this hybrid implementation where, yes, it is digital, but some cities have this physical engagement. The second goal is to estimate the prevalence and characterize patterns of syndemic experiences among transgender women. The third aim is to estimate HIV incidence among transgender women, and there's also a big focus on characterizing the PrEP continuum among this population. And this follows from the light cohort that was also very focused on PrEP. So basically trying to improve PrEP access for transgender women and understand why uptake has been lower among this population. And finally, the last aim is to develop dynamic models of multi-level combination HIV prevention. So basically estimating the potential impact of interventions in the same way that I did for ImPrEP. So I'll take you through the plans for the modeling. So there's three main goals for the modeling. One is to better understand epidemic dynamics through quantifying the contribution of different individual, interpersonal, and structural drivers of HIV incidence among transgender women. The second one is to identify optimal PrEP regimen and delivery strategies. So how should we be delivering PrEP among this population? And the third one is to design HIV combination prevention packages to achieve the EHE, the HIV elimination goals by 2030. And we're going to be focusing on 4 regional models representing the Northeast, South, Midwest, and West. And all of the modeling process is going to be conducted in collaboration with the community and the Community Advisory Board. So this is a diagram of the model. This is actually a very ambitious diagram. I don't think we're going to be representing all of these for each of the regions, but basically the model will be obviously representing HIV progression through susceptible, acute, latent, pre-AIDS, AIDS. This is the like standard way in which HIV is represented in these models in order to represent different HIV transmission probabilities in these different stages of the disease. We will be representing PrEP care, so daily PrEP, but also event-driven PrEP and long-acting PrEP. And then we're going to be representing ART care and whether people are diagnosed and on ART or diagnosed not on ART or diagnosed on ART. So all of those combinations are considered. And then the main research questions will be answered here. So the population will be disaggregated in function of their determinants of HIV risk. So we have age as a basic determinant of HIV incidence, with younger people generally having a higher incidence, race, ethnicity, mental health, substance use, sex work, intimate partner violence, unemployment, and access to healthcare. And so basically what we're doing here is representing individual, interpersonal, and structural risks. So we're basically reproducing the socio-ecologic model of risk by representing some of the risks associated at each level. It is very rare for a model to represent so many things, and it will very much depend on power of the statistical analysis to see whether we are able to get meaningful estimates for each of these. But what I think will end up happening is that for each region, the key determinants driving risk will be identified and then represented in the model. And so this is for transgender women, but we're obviously also representing their male sexual partners, but we won't have as detailed data among those male sexual partners. And so those will only be disaggregated by race, ethnicity, and substance use. In the survey, transgender women are asked about the race of their race and ethnicity of their male partner. So it will be possible to estimate that directly from that at least. And I mean, I would need to go in a lot more detail to explain how we're going to be representing HIV risk associated with each of these determinants, but very briefly, we assume that those who are young will have a reduced rate of PrEP initiation and an increased number of partners. And so that's how we will reproduce higher incidence rate among those at younger ages. For risk associated with race or ethnicity, we will have a different distribution by employment status, substance use, sex work, and healthcare access. And those different groups will be associated with different risks. Hazardous alcohol use or illicit drug will represent increased risk of condomless sex and sex work engagement among those who engage in substance use. Mental health disorders, if they will have an increased risk of substance use, selling sex, increased number of sexual partners, and condomless sex, which will be dependent on employment and substance use status. IPV exposure, increased risk of condomless sex, mental health disorders, and reduced access to healthcare, and unemployment, reduced access to healthcare, and increased mental health disorders, and poor access to healthcare, basically reduced rate of HIV diagnosis, ART, and PrEP initiation. I'm showing you this just so that you see that everything is interrelated. And so the novelty with this model is that it's actually looking at those relationships between race and other risks that are lower in the causal pathway of HIV acquisition. And so it's basically trying to understand how these different risks relate to each other and not to double count risks. And so there's going to be lots of statistical analysis happening to inform these, to basically look at independent associations between these risks and HIV incidence. We're going to be calibrating the model, using approximate Bayesian computation. And we have data on HIV prevalence from the NHBS survey for several time points. And then there was a special one for transgender women in 2019-2020. And so we're going to be pulling CD estimates in each of the city for the 4 regions to calibrate the model. And we're also going to obviously be using data from the cohort on HIV prevalence and incidence, both the light cohort, but that's only for northern and southern US, and for the ENCORE cohort, which is 4 regions. And finally, we'll obviously also do a literature review to get local HIV prevalence and incidence and ART coverage estimates. So the plan is that each regional model will serve as a platform to implement city-specific analysis. So that, for example, if we do a model for the West, and we want to model, well, I'm cheating with San Diego, but we want to model San Francisco, we will use the West model, and then we will input city-specific estimates as far as they are available. So in some cases, the city model will be very, very similar to the regional model. In cities where there is a lot more data, then the results will be much more in line with what we expect is true for that city.
Got 1 minute.
1 minute, okay. Well, I think that's it. I was gonna take you through the kind of like modeling analysis, but basically, yeah, estimating the contribution of different epidemic drivers to HIV incidence, identifying PrEP delivery strategies. This is going to be very much informed by the analysis of the AIM-3 of the grant, and then basically design combination prevention scenarios to reach the EHE target in 2030. Basically to tell different regions and hopefully cities how they should deliver HIV combination prevention to achieve these targets among transgender women. And basically, thank you to all colleagues and collaborators involved, to our current and future participants. We're still missing about 2,000 participants, so I'm thanking them in advance for their participation. And thank you for listening. And this is just, well, you can't read it actually, but something that the ENCORE study produced on Transgender Women Visibility Day about violence and premature death among transgender women, which I'll be happy to share for those who are interested. If anybody wants to share information about the ImPrEP study, here it is. And this is some initial results from participation from the end of enrollment in the spring. So thank you.
Thank you, Annick. So I think we have a few comments from Nettie. So in regards to the earlier study, she said $587 per year is pretty low, but I think estimates and cost for new HIV infection should include staff costs because HIV specialty staff are more expensive and there is a workforce shortage versus not including staff costs for the PrEP patients because they are presumably using existing STI clinic staff.
So Natty is saying that it is...
She feels like you should include the staff costs.
Both for the PrEP and for the HIV, sorry, for the ART. Yeah, I mean, to be honest, I agree with Nettie, and there was a lot of discussion around that, and the fact that with discussions with the Ministry of Health, there's like, well, there's not going to be more hiring, so why would we incorporate the cost of hiring if that's not going to happen? So, yeah, I'll be presenting both, but I agree with Natty that including personnel costs is important because it's an added service.
Yeah.
So it's an added cost.
All right, last question from Nettie as well. Thinking about the Lima incidence being higher than anticipated,
how do these models handle possible disruptions such as surges in substance use, like we are seeing here in San Diego with meth and fentanyl, which may be rapidly changing the HIV incidence landscape?
Well, they don't. So that's the thing, that these models generally estimate very stable behaviors through time. They're modeled using sentinel surveillance behaviors. And the sentinel surveillance is implemented every few years, so you don't have very frequent information. And I think the main issue here is COVID, that there was a lot of immigration from Venezuela. Many of the ImPrEP participants are from Venezuela. There was a high incidence among these population because, I mean, they're obviously facing very difficult living situations. And so disentangling what was associated with COVID and with these changes in migration patterns and what's the common incidence is difficult. So yes, so there is this risk that it is a temporary thing that happened and that all of these results from ImPrEP are reflecting a very specific period in time. But at the same time, we can't ignore the results. So that's why we're basically going to be presenting both.
Okay, well, great. I know we're a little bit over time, so I wanted to thank Dr. Annick Borquez for an excellent talk. And reminder, we do have high rounds next week, so hopefully we will see you there. Have a happy World AIDS Day and have a great day. Thank you, everyone.